Good morning. Can you hear me?
Yes.
Can you see the screen?
I can hear you and see the screen.
All right. Okay. I'm going to wait about a half a minute. There were 50 people pre-registered and only not quite half have signed in. So I'm going to wait another little half a minute and then I will get started. Okay, let's go ahead and get started then. I am Eileen Doherty, and I am the director of the Colorado Gerontological Society. Thank you all for coming to our Wednesday Lunch and Learns. Today, we're going to be talking a little bit about the 2026 Medicare Advantage changes. And as probably most of you know, the purpose for these Wednesday Lunch and Learns is to really dive a little bit deeper into specific Medicare topics or issues that can help with your decision making. So today, as I said, we're going to talk about Medicare Part C, which is also known in the world as Medicare Advantage. So some of you have seen this slide many times. For others, it might be new, but I have and want to stress to you that Medicare has parts, and the insurance companies that support Medicare have plans. So Medicare has 4 parts: A, B, C, and D. It's supported by insurance companies, which are Medicare Advantage plans, which sells Part C, prescription drug plans, which sells Part D, and Medicare supplement plans, which support, if you will, Medicare A and B. And the reason I want to make sure that you understand that is that if you are asking me a question, and while in the English language, we use these words of parts and plans oftentimes interchangeably, if you want me to answer a question related to parts, then make sure you're asking a question about Medicare. If you want to ask me a question about the plans, then make sure that you're using that language so that I or anybody else who is trying to answer your questions is answering the right information. So even if you are in a Medicare Advantage plan, you always have to pay your Part B premium. You have to be enrolled in Part A and B. And if you have a Part A premium, which most people do not, most people who have worked with for 40 quarters of Social Security will get Part A for free. But Part B, there is a premium, and the projected premium at the moment is $206.50. Do not confuse the Part B premium, which comes out of your Social Security check, with the premium that is charged by the Medicare Advantage plan. Now, some of you may take advantage or are already taking advantage of a Medicare Advantage plan that has a zero premium. And if that's the case, that's okay. But people frequently tell us that they get confused about continuing their Medicare Part B premium that comes out of their Social Security check with their Medicare Advantage premium. This is a graphic that reinforces, if you will, or shows that Part C is basically Part A, Part B, and Part D all together. Okay. So again, Part C is the Medicare Advantage, and as an overarching program, it for sure combines Part A and B, and oftentimes includes Part D as well. What are some of the features of Medicare Advantage? One is that it has to provide all of the services that original Medicare provides. And if you're looking for a list of those are such things as office visits, primary care visits, emergency rooms, ambulances, labs, x-rays, preventive screenings, all of that kind of thing. Plus, it has to provide inpatient hospitalization, has to provide skilled care following a 3-day hospital stay in a rehab center, has to provide home care, again, assuming that you have had a 3-day hospital stay. The hospice services are usually provided by original Medicare, but basically they have to provide the same services. The benefit package that the Medicare Advantage negotiates with Medicare every year usually has some variation. So the original Medicare services, those look the same year over year over year. But they can add dental, or they can add vision, or they can change out the copays, or they can change the prescription drug benefit, or they can change the formulary for which drugs are on which tiers. In my experience, the services change every year as well. So there seems to be a lot of changes in hospitals, in doctor networks, in pharmacy networks. I was in Montrose earlier this week, and they were telling me about the difficulty they had in buying prescription drugs this year because it's not a very large community. They have a limited number of pharmacies, and one of the managed care or Medicare Advantage plans was not doing business with 2 of the pharmacies. So people had to be really careful about which pharmacies were in network and which weren't. So it's not maybe so much that the services change, but the providers change. Another thing that we saw this year was significant changes in dental benefits. What it's going to look like for next year, again, we'll see a lot of changes, and you'll have to check the plan that you have if you are enrolled in one or you are planning to enroll in them. Medicare Advantage frequently also uses a prior authorization system in which if you need certain kinds of services, those have to be prior authorized. What that means is your doctor thinks that you need a knee replacement, and the company or the Medicare Advantage plan says to the doctor, have they tried therapy? And if the doctor's answer is no, they probably will not prior authorize the knee replacement until you go do therapy. And then once therapy has completed, if there has been an improvement, great. If there has not been an improvement, then the doctor can resubmit for a knee replacement. So again, there's a lot of that prior authorization that happens. The plans for Medicare Advantage are sold by agents or brokers, but you can also enroll yourself online at the Plan Finder, very similar to the way you would enroll if you were in original Medicare with or without a supplement and enrolling in a Part D or Medicare Advantage plan. So again, to reiterate, an MA plan is Part C. Many plans offer a zero premium, but many of their procedures require a copayment that can be as high as 20% of the cost if you were enrolled in original Medicare. So we're going to look next at the chart, basically in which Part A, we just repeated that the benefits are hospital skilled nursing with a hospital stay, home health, and hospice. Part B are the physician preventive services, labs, durable medical equipment, diabetic supplies, mental health services. Part D are the drugs on the formulary. Now, what makes a Medicare Advantage somewhat different is the next two columns. So on the supplemental benefits, this is where frequently people are interested in signing up for a Part C plan because they may have eye exams or glasses. They may offer a dental benefit. They may offer hearing aids. Oftentimes, there's a lot of variation from year to year in terms of what those look like, how often you can get a new set, what the maximum benefit is. All of that is very variable based on the company and what they have filed with Medicare for this coming year. Some of them offer fitness programs like Silver Sneakers or Denver Health. Used to work with the Parks and Recreation Department of the City and County of Denver. Sometimes they offer transportation. Sometimes they offer over-the-counter products, like you'll get a card that gives you a $100 benefit at a local pharmacy or programs such as a Walgreens or a CVS. And you can buy things like aspirin and Tylenol and those kinds of things. Some of them also give these cashback cards where what you are able to do is sometimes get a reduction in your Medicare Part B premium. Some of them also offer a thing where you can use the money on a credit card, and the purpose for that is that you can pay for out-of-pocket expenses such as rent or utilities or those kinds of things. Those are going to be less popular for 2026, or less, I should say, not popular, but less available. The other column that sometimes people qualify for is the SSBCIs, or the special supplemental benefits for the chronically ill. And basically, Medicare has sort of put on more parameters this year for who can get these SSBCIs. So they are things like meal delivery, but you as an individual have to be at risk, like of hospitalization or dying, or your situation has to be advanced significantly. Similarly with rides and in-home support. So this is going to be less available. And if you had some of those services this past year, they may or may not be as available if you stay either with the same company or if you switch. Let's look then at some of the out-of-pocket costs for a Part C plan. It may have a monthly premium. Almost all of the plans have a zero premium. There will be usually some type of a copay for most visits. And usually it's a standard amount. If you go to see your doctor, it might be $10, $20, $30. Specialists oftentimes are higher, might be $30 or $40. Emergency rooms and urgent care and inpatient hospital usually have a standard amount. So the emergency room might be $50 or it might be $125. Inpatient hospital usually has a $100, $200, $300 copay for a certain number of days. So it might be like $200 for days 1 through 6. If you're only in the hospital 3 days, it might be $200 for days 1, 2, and 3. If you have to go to skilled rehab in a nursing home, days 1 through 20 are free, but then 21 through 100. So if you have to stay longer than 20 days, you would have to pay that copay out of pocket. This year, that's about $214 per day. Usually, you have to pay a 20% copay for most Part B services or a percentage of their negotiated rate. So you might have to, if you had, say, an MRI and they had negotiated with the hospital that the cost was going to be $8,000, your 20% might be $1,600 for that negotiated rate. Prescription drugs also usually have some kind of a copay, again, depending on the tier. Oftentimes, tiers 1 and 2 are no copay, but tiers 3, 4, and 5 often are a percentage of the cost of the drug. So if you had a drug that was $200 and it had a 20% copay, you might have to pay $40 for that prescription. If it was, say, a tier 3 or a tier 4 drug. If it was a tier 1 or 2 drug, you might not have to pay anything. Part C plans do have, set by the federal government, a maximum in and out of network cost. So your in-network cost cannot be more, that comes out of your pocket, of $9,250 next year. Your out-of-network cannot be more than $13,300. And I'll talk a little bit more in a future slide about in and out of network. Some plans are also following the standalone Part D plan for deductibles and maximum out-of-pockets. Again, some are doing less than that. There's nothing that says they have to do it, but some are doing it. So in addition to your in-network or out-of-network plans that you have, you may also experience additional prescription drug costs. Other things to know is that, as I said a few minutes ago, the Part A deductible is usually a set amount. Usually there's also not a Part B deductible. So if you're an original Medicare with a Medicare supplement, you have a Part B deductible. But most of the time, those are waived and you just have a standard set price. They have the negotiated annual out-of-pocket caps, which are the maximum in and out of network that we just spoke about. The agency or the company can also waive any prior authorization rules anytime they want. They also, if you have pre-existing conditions and you want to leave the Medicare Advantage plan, if you first enroll in the Medicare Advantage plan when you turn 65 or are first eligible for Medicare, you can go back to a Medicare supplement after the first 12 months. But usually after that, if you are in a Medicare Advantage plan, you have pre-existing conditions, you usually cannot go back to a Medicare supplement, but you can change from one Medicare Advantage plan to the other. The other thing is that Medicare Advantage plans have what we call star ratings, and we'll talk about those in a minute. Medicare Advantage, as all Medicare services, operate on something called medical necessity. If you have a question, if you want to put it in the chat, or if you want to write it down till we finish, that would be great. So the way medical necessity works is that according to the Medicare rules, no Medicare payment shall be made for items or services that are not reasonable and necessary for the diagnosis or treatment of illnesses or injuries, or to improve the functioning of a malformed body part. I always get a kick out of this definition, but one that Medicare has continued to use for as long as I have been doing this work. So medical necessity is how prior authorization is usually determined. So if a company, whether it's a Part D plan, whether it's original Medicare, and they're starting to do some prior authorizations, or whether it's a Medicare Advantage plan, this is the definition that they work with. The prior authorization changes in the past year, going into effect for next year. There have been some changes that Medicare has put into place. So one of the things that a Medicare Advantage plan will no longer be able to do is if they give you a prior approval during your hospital stay, that has to hold. So if they've given you a prior approval for a 3-day hospital stay, that has to, they can't change that and reduce it down to a 2-day stay. If there is a request for a prior approval, Medicare is trying to make that happen more quickly. So the plans will have to review those within 14 days, unless it is an expedited appeal. If it's an expedited appeal, they have 3 days or 72 hours to review. If it's just a general appeal, they'll have 14 days to review it and get back to you or the provider in 2026. They also are looking at making the appeal process easier for older adults or Medicare beneficiaries, because when Medicare looked at the data, they said that there were a number of denials that were overturned when they were appealed. And so in an effort to make it easier for older adults or Medicare beneficiaries to question or to request a service, they're trying to make the appeal process a bit more consumer friendly. Another thing that is happening this year is something called value-based care. And this is an attempt, again, to help people who are losing their primary care physician for whatever purpose or reason. So what they have done is that there are 3 companies at the moment that I am aware of. There may be others that are primary care clinics. There is Archwell, Oak Street, and One Medical. And the goal or the idea of these primary care clinics is to provide you as a Medicare beneficiary with longer appointments, more frequent primary care visits, and more personalized care that focuses on overall wellness. These clinics have written contracts with some of the Medicare Advantage plans. And I've listed which plans they have contracts with. If you have a Medicare Advantage plan that is not listed on one of your preferred clinics, please contact the plan or contact the clinic, as they may have added that Medicare Advantage plan to their system in which they're able to bill. It's important to note that Oak Street and One Medical also take original Medicare with a Medicare supplement. At this point in time, Archwell is not taking original Medicare. That may change, but at the moment it is not, they are not taking them. And I did verify that with them. So now we have, again, this year, some special election periods. And this may be affecting some of you. So if your Medicare Advantage plan is leaving your service area or no longer offering coverage, you can qualify for something called a special election period. Now, a really big change this year is that Cigna has changed their name. They were bought out a couple years ago to HealthSpring. So if you have a Medicare Advantage Cigna plan, you have a special election period. You can go to HealthSpring, which is the new Cigna. You can go to a different MA plan, or you can sign up for a Medicare supplement without underwriting and with regardless of your pre-existing conditions. Similarly, United and Humana have dropped some of their PPOs, or preferred provider organization plans. These also trigger the same thing. You can sign up with a different Humana or United plan that they offer, or you can sign up with a different MA, or you can sign up with a Medicare supplement. And some companies are also dropping their special needs plans or their SNPs. So if any of these affect you, then basically, just to reiterate, you can choose a different Medicare Advantage plan with or with that company that dropped you, except Cigna, where you have to change companies. You can enroll in a Medicare supplement with no underwriting, but you also have to enroll in a standalone prescription drug coverage plan. And your coverage in this new plan will start January 1, whatever it is that you change to. Another change that is happening this year on the Medicare Advantage side is that they are expanding their reach for SNPs or special needs plans. They are targeting individuals who receive Medicaid, not Medicare, but Medicaid for enrollment. So in order to qualify for a special needs plan, you have to be receiving both Medicare and Medicaid. And part of the special needs plans is that they can provide some additional medical services and therapies. They have a provider network, which may be the same or somewhat different than their regular provider network. They can provide mental health and counseling. They spend a lot of time doing complex case management. They have some benefits for like medical equipment and devices. Oftentimes those don't necessarily have a copay. So if you have, say, oxygen, and you were in a special needs plan and you were on Medicare and Medicaid, you might not have a copay for oxygen. There are 3 different types of special needs plans. So again, in Medicare's true fashion, they never make anything easy. So a D-SNP is the one that is most frequently promoted by the Medicare Advantage plans and available to the largest number of people. So a D-SNP is basically somebody enrolled in Medicare and Medicaid or the Medicare Savings Program. And usually they have a zero or monthly premium, but basically they're most widely available. A C-SNP is for chronic disease. So you have to have the chronic condition that the company, the Medicare Advantage plan, has contracted with Medicare or CMS. So usually this is something like chronic obstructive pulmonary disease or end-stage renal disease or something like that. So you have to have one of those diseases to get that. I know there's at least one or two companies that are offering some of those, but one or two companies that were offering C-SNPs are no longer offering them as well. And so if you happen to be in one of those and you want to continue, you probably will need to enroll in a company that's offering it. And then we have what we call I-SNPs, and I stands for institutional. So basically this is restricted to people who live in a skilled nursing facility for 90 days or more. And you have to basically meet the Medicare and Medicaid requirements as well. So this is the explanation for the in and out of network. And Medicare Advantage plans use provider networks. Medicare supplements allow you to go to any doctor, any hospital, any skilled nursing facility in the country that accepts Medicare. But the Medicare Advantage plans use these networks. So if you are in network, and you will see that language, this is a group of providers, doctors, hospitals, pharmacies, rehabs, home care agencies, etc., that partner with the insurance company, and they have agreed to accept a negotiated or discounted rate for services that they provide. So as an example, your doctor may have agreed that they are going to take all individuals from Medicare Advantage A for $75 per visit. That becomes the negotiated rate or the discounted rate. If I went there as an individual person in original Medicare, the doctor might charge me $100 or $125. If you are in the network, your copay is usually lower. So if you are looking at oxygen, for example, it might be 20%. Or if you're looking at the copay for a doctor visit, it might be $20. And those are all pre-negotiated, if you will, with Medicare and printed in your summary notice. Ambulance and emergency rooms are usually treated as in-network, regardless of whether they're originally in the network or not, basically due to the emergency nature of whatever the condition is. So if you are having a heart attack and you are closer to, say, University Hospital, and they're not in the network for your Medicare Advantage plan, but the ambulance takes you to the emergency room at University Hospital, that Medicare Advantage plan pretty much would have to pay because you're having a heart attack, and we're most concerned with getting you care, not how it's going to get paid. Out of network then means that the provider does not partner with that insurance company. And the insurance company, when that provider is usually charged the full price. So what that does is it increases the expense for the insurance company. And so what the insurance company is going to do is or the MA plan, they're going to cost share that with you with usually a higher copay. So it might be 40 or 50%, or it might be $40 versus $20. And those, again, all vary depending on who the provider is and what the situation is or what the provider has. There's usually a cap, as we talked about, is $13,300 across the board. Now, your company may have a lower cap than that, but that's the maximum set by Medicare that they can charge. And then why would you choose to go outside of the network? Well, it might be the expertise of the specialist or the company or the provider that you're working with. It might be your location. It might be that you want continuity of care. There might be other reasons, but those are some of the kind of general reasons. So now let's talk a little bit about hospital and provider network changes for 2026. So there are more of these, but I'm going to just use these three, which I have encountered over the last couple of weeks. So one is that UC Health has decided that they are no longer doing business with Devoted. The San Luis Regional Medical Center, which is in Alamosa, has announced that they are no longer doing business with Humana. Similarly, the Montrose Regional Health Center, which is the hospital down there, has announced that they are no longer doing business with Humana. So if you have Devoted or Humana and you use those providers, if you want, your options are, if you want to stay with your doctor at UC Health, you can choose a different MA plan, a Medicare Advantage plan that has a contract with UC Health. The sort of traditional plans with the zero premiums, none of those plans at this point are contracting with UC Health. But UC Health does have some plans, some MA plans that they're contracting with that maybe don't have a prescription drug plan, or they're contracting with an HMO that has a point of service, or they're contracting with a specific PPO. Often these are going to cost more premium and your co-pays may be higher. But again, that may be very important to you to stay with your doctor at UC Health. And so switching to one of those plans may be the best thing for you. If you want to stay with your Devoted plan that has a zero premium or any other Devoted plan, you can select a doctor from their provider network and you can just stop going to UC Health. Now, if you are Cigna, they also have decided that UC Health has given notice that they are not working with Cigna, now HealthSprint. So again, if you want to stay with your doctor, you can do exactly the same thing that you would do with Devoted or Humana. If you want to stay with Cigna or their new company, HealthSpring, you can find a new doctor from their provider network and go to UC Health. Cigna has a little different opportunity. When we talked a few minutes ago about a special election period, you can, if Cigna gave you notice that they're not working with UC Health, you can actually go back to original Medicare, enroll in a Medicare supplement without any underwriting, because you now have a special election period, and you can go to any doctor you want, including UC Health, and basically then they can bill your Medicare supplement. One thing you have to be sure about is that if you go to UC Health, your doctor will accept the Medicare supplement. So make sure you check that out. If you have received a letter from a hospital or another provider, doctor's office or whatever, that they're no longer accepting your MA plan, then again, check with your agent, or you can call our office and talk about what your options are. But if you have received any kind of letter that says they're not working with a hospital, a doctor, a nursing home, that kind of thing, then this slide applies. If you have received a letter that says you are no longer covered by the Medicare Advantage plan, then the previous slide applies. Another requirement, this is not new this year, was new a couple years ago, but I wanted to make sure that everybody was aware of it, is they have to put, agents and brokers have to put this disclaimer on all of their marketing materials. So it says, we do not offer every plan available in your area, and any information we provide is limited to those plans we offer in your area. Please contact medicare.gov or 1-800-Medicare if you want to get more information. This information has to appear in the first minute of a sales phone call, has to appear on their emails, online chats, or electronic communication, has to be displayed on their websites. Any of their marketing materials have to be in 12 font, and it has to appear in television advertisements. So again, this is Medicare's attempt to basically let you know that whatever's being advertised is not available, and that it in every market, and that, again, helping you understand what's available. The same requirement for sales calls went into effect a couple years ago. So you may have signed up through the newspaper or some other marketing event to receive phone or Zoom calls from a health insurance agent. And if you have, those calls have to be recorded. So all conversations, that's a sales lead, even if they're 5 or 6 calls before the beneficiary makes a decision, have to be recorded. If they call to schedule an appointment, that appointment call, the scheduling as well as the appointment, has to be recorded. If they're collecting information, or if you're collecting information about drug and provider lists, education meetings, phone enrollments, follow-up calls, all of that, either from a cell phone or a landline, has to be recorded. The exceptions to that are if you go to an in-person meeting that is advertised as a sales and enrollment meeting. Those do not have to be recorded. Or if you get phone calls or in-person meetings for Medicare supplements, unless they're also selling you a standalone prescription drug plan, then it does have to be recorded. Whoops. These are the companies that are selling Medicare Advantage plans in Colorado this year, but it does not mean that they are selling in every zip code and every county. So just because their name appears here does not necessarily mean that they are selling where you live. So my best guess, I haven't actually checked, is Elevate, or formerly Denver Health, is probably not selling much outside of the city and county of Denver. They may be selling a few zip codes outside of that, but Denver Health has always seen their primary target as residents of the city and county of Denver. Similarly, some of these companies are in like certain parts of the state and not other parts of the state. So you need to check and make sure. This is the slide on star ratings. All MA plans have a star rating, and they're rated from 1 to 5, with 5 being excellent or the highest. Those ratings are based on member experience. So if you are a member of an MA plan, you might get a survey that asks you a bunch of questions. And those do come. I've seen those for my clients over the years. I've helped my clients fill them out. They are based on customer service. How well do they respond to questions that they might get? How many complaints do they get? These last two really look at how do they provide services. So one is, how do they manage your chronic conditions? What kind of tests do they recommend? What kind of treatments do you take? So say, for example, you had advanced lung disease, and they were recommending that you have some pulmonary tests, some walking tests, various kinds of treatments associated with that. If you followed through and the records on follow-up show that you followed through with those requirements or those tests and treatments, that would be a positive for the company. If they didn't recommend them, that would be a negative for the company. And then the other thing that they look at, they being Medicare, is what kinds of things do they do to keep you healthy, like screening tests. So do they do an annual mammography? Do they do various kinds of other tests, vaccines, preventive checkups? So those are all graded. If you have a company that has a 2-star rating or a 1-star rating, they cannot sign up new members. We don't have any of those companies in Colorado. We also don't have any with 5 stars. So this is just a quick overview of what Medicare looks at. So Medicare contracts with the Medicare Advantage. They have to provide the same services as original Medicare. Their networks and their marketing materials have to be approved by Medicare. They have to participate in these quality assurance programs, which is this star ratings that we just talked about, and many other programs. And the members can change plans annually, which is where we're at now. Any changes that you want to make need to happen between now and December 7th. So the next couple of slides basically are help paying for Medicare Part B and D. So B is the Medicare Savings Program. If your income is below $1,781 per month, or $2,400 for a couple, and you have less than $13,100 in resources, excluding your house, your car, a burial plan, and a term life insurance, you can get some help paying your Part B premium, which this year is that $187. Projected, if you remember, we saw originally maybe as high as $206 for next year. So that can be helpful. You can enroll for this either at the County Department of Human Services or at Colorado Peak, and they'll pay the Part B premium. If you're really low income, then they can also help with deductibles and copay and co-insurance. These individuals are also eligible for those special needs plans, which might also get you some additional help. The other thing is Extra Help, and this is the program that pays for help with prescription drugs, both on the premium side as well as copay. And the income and resource limits are a little higher. So you can have $1,956 per month, or a couple $2,643, with a little bit higher resources of $17,600 and $36,130. And again, those exclude your house, your car, a burial policy, and your term life insurance policy. And for this program, you apply at Social Security. And you can either go to their website and sign up online, or you can call 1-800-772-1213. Not all, again, Medicare Advantage plans accept the Extra Help and Medicare Savings Program. So again, you have to check with the company and see if that is an option that's available. So that concludes my remarks, basically, for the differences or what is happening with Medicare Advantage for 2026. A couple of things for you to just maybe know about is that Representative McCormick and Representative Brown are planning to carry a bill in 2026 to make it easier for people who currently have a Medicare Advantage plan and want to go back to a Medigap plan without having to be underwritten and giving you a guaranteed issue. The bill has been drafted. I have seen some preliminary drafts, but I expect it to be filed sometime next week or the week after and to be introduced in January. CGS is here to help with our Medicare Monday in-person events, and we have a few of those left. If you haven't already, you should receive some emails to that effect. If you are new to Medicare, I am doing one more session on December 1, and I believe it's at 4 p.m. It's a Zoom session. If you are interested in more of our Wednesday Lunch and Learns, there are a couple more of those available. I have not got these self-enrollment guides posted yet. We do have a couple of brokers who have signed up to be preferred brokers, and you can always call our office if you have questions. I do have preferred brokers whom we have been working with. I have one in Denver and one in Northeast Denver or Northeast Colorado and one in Colorado Springs. This is just a summary of the programs that CGS offers, and you're welcome to go to our website and check any of those out if you would like to take advantage of them. These are other programs that we offer, and again, you're welcome to go check any of those out and get more information either at our website or our YouTube channel. And with that, I will close this presentation. Thank you for joining us. Okay, I am now going to go to the chat and answer those questions. So the first question is, do value-based practices have specialty physicians or just primary care? My understanding is just primary care. The next question is, are standard vaccines, COVID, flu, shingles, RSV, still covered under Medicare for 2026? And the answer to that question is yes, but please make sure that you go to the right provider. So you could get all 4 of those vaccines at the pharmacy and have those fully paid for. You could get a flu vaccine at your doctor's office and have that paid for. But if you do a COVID, shingles, or RSV at your doctor's office, Medicare will not cover them. Now, that may be different for certain MA plans, such as Kaiser. Kaiser gives those vaccines at their clinics, and so they have a little different setup. The next question asks, what does no underwriting mean? What that means is that if you have pre-existing conditions, such as, let's say you had high blood pressure and you had a heart condition and high cholesterol, what that means is that if you have a special election period, meaning this year, right now, Cigna, you had a Cigna plan, you had a Humana plan, or a United PPO, or some D-SNPs, you can enroll with a Medicare supplement, and they don't care about your pre-existing conditions. They have to take you. If you don't have a special election period and you go to change Medicare supplements, or you change from a Medicare Advantage to a Medicare supplement and you're past your 6-month initial enrollment period, then the Medicare supplement can ask you questions about your pre-existing conditions. And if they decide you're too high of a risk, they don't have to sell the policy to you. Medicare Advantage can never do underwriting. They always have to accept you regardless of pre-existing conditions. The next question says, I would like to know more about reasonable necessity for medical necessity authorization qualification descriptors. If you go to this, and this is not the CMS.gov, but go to the Centers for Medicare and Medicaid Services website, there are numerous explanations. If you just put that in your search bar, you can get better information from the Medicare website, not the Medicare Gov, because Medicare Gov is just the area of Medicare's website that helps you with enrollment and providers and those kinds of things. But the actual like regulatory section, which is the Centers for Medicare and Medicaid side of the benefit, you can get more information about that. That is all of the questions that are in the chat. Does anyone else have a question you would like to ask? Okay, well, thank you all for joining us today, and I will send out the slides to everybody who pre-registered. And I'm hoping that within the next few days, the presentation will also be up on our YouTube channel. My person who is doing that has not been available the last few weeks. So thank you all for joining us, and I will talk to you soon.